So Pathology, Chapter 1, Cellular Reaction to Injury, Key Issues, Hypoxia, Cyanide, Poisoning, Free Radicals, Hypothesis, Grow alterations, such as hypertrophy, atrophy, hyperplasia. So first we talk about hypoxia, inadequate oxygenation of tissue, same definition as shock, need oxygen for oxidation phosphorylation pathway, where you get ATP from inner mitochondria membrane, electron transport system called oxidative phosphorylation. The last reaction is oxygen to receive the electrons. Protons are being kicked off, go back into the membrane and form ATP, and ATP inform in the mitochondria. So some terms we need to know. So first, oxygen content is hemoglobin and oxygen saturation. Uh, Hemoglobin times oxygen saturation plus partial pressure bacterial oxygen. So these are the three main things that carry oxygen in our blood: hemoglobin, oxygen saturation, partial pressure bacterial oxygen. In hemoglobin, the oxygen attached to heme group on oxygen saturation. Partial pressure of bacterial oxygen is oxygen dissolved in plasma, not in hemoglobin. And in red blood cell, for heme groups, iron must be disobliged to E plus 3 cannot carry oxygen. Therefore, when all four heme groups have an oxygen on it, the oxygen saturation is 100%. So oxygen saturation is oxygen in red blood cell is attached to the heme group. So it's measured by pulse oximeter. Number 3, talk about partial pressure of oxygen. Is oxygen dissolved in plasma. Oxygen saturation is oxygen in red blood cell is attached to the heme group, which is in hemoglobin in heme group. So measure by pulse oximeter. So oxygen saturation, which is measured by pulse oximeter. Oxygen saturation with pulse oximeter and partial pressure of oxygen. As the oxygen dissolves in the plasma. Okay. Oxygen flow is from alveoli through the interface, then dissolves in plasma and increases the partial pressure of oxygen, diffuses through the red blood cell membrane and attached to the heme groups on the red blood cell, on the hemoglobin, which is the oxygen saturation. Therefore, if partial pressure of oxygen is decreased, keep in mind partial pressure of oxygen, that's oxygen dissolved in plasma. So if partial pressure of oxygen is decreased, the oxygen saturation has to be decreased because oxygen comes from a amount that was dissolved in plasma. So keep in mind if partial pressure of oxygen, which is oxygen dissolved in plasma, if partial pressure of oxygen decrease, then the oxygen saturation has to be decreased. The reason why, because the oxygen comes from amount that was dissolved in plasma. Okay, so the next one, causes of tissue hypoxia. Hypoxia, we know that's an inadequate oxygen of tissue, huh? That's now the cause. Number one, which is ischemia, you know, ischemia, which is a decrease in arterial blood flow, not venous. Most common cause ischemia is thrombus in muscular artery because this is the most common cause death in USA. Myocardial infarction. Therefore, myocardial infarction is a good example of ischemia because thrombus is blocking arterial blood flow, producing tissue hypoxia. Other causes of tissue ischemia, the decrease in cardiac output, leads to hypovolemia and cardiogenic shock because there is a decrease in arterial blood flow. Okay, so ischemia, which is decrease in arterial blood flow, not venous. Ischemia, which is arterial blood flow, not in vein but in artery. Most common cause ischemia is thrombus in muscular artery because this is the most common cause of death in USA. Most common cause of death in USA is a myocardial infarction. Therefore, myocardial infarction is a good example of ischemia because thrombus is blocking arterial blood flow, producing tissue hypoxia. Other causes of tissue ischemia, which is decrease in cardiac output, leads to hypovolemia and cardiogenic shock because there is a decrease in arterial blood flow. Second most common cause of tissue hypoxia is hypoxemia. Hypoxia, which is midterm hypoxemia, cause of hypoxia, they are not the same. Deals with partial pressure of arterial oxygen, which is oxygen dissolved in arterial plasma. Therefore, when the partial pressure of oxygen is decreased, so this is called hypoxemia. So partial pressure of oxygen decreases, so we call this a hypoxemia. And keep in mind, partial pressure of oxygen if decrease, then decrease of oxygen saturation. The reason because partial pressure of oxygen, that's the oxygen dissolved in plasma, right? So if this amount decrease, so then the oxygen get into red blood cell, so which in hemoglobin, which is oxygen saturation also decrease. So in that time we call this hypoxemia. There are four causes of hypoxemia. First of all, is a respiratory acidosis. In terms of hypoxemia, in terms of Dalton's law, the sum of partial pressure of gas must equals 760 at atmospheric pressure, have oxygen, CO2, and nitrogen. Nitrogen remains contained. Nitrogen remains constant. Therefore, when we retain CO2, this is respiratory acidosis. When CO2 goes up, so PO2 has to go down because must have equal 760. So keep in mind, follow the Dalton's law. The sum of partial pressure of gas must constant, which must equal 760, right? So equal to 760 at the atmospheric pressure. So nitrogen remains constant. So if CO2 increase, then O2 have to be decreased. Because acidosis which is CO2 increase, right? Respiratory acidosis. So that stands for what? That stands for we keep more CO2 in bloodstream, which is some problem. We cannot get the CO2 out of the body, or uh, or we get too much CO2 in the body for some reason. So if CO2 increase, then O2 must be decreased. So in respiratory acidosis, so this acidosis due to ventilation, to respiratory system, which is due to airway. Uh, so if CO2 increase, and we know this O2 have to be decreased. So then in respiratory acidosis, and we know O2 decrease. But if O2 not decrease, then we know patient doesn't have a respiratory acidosis. Can we make conclusion like that? The reason because follow the Dalton's law, so the partial pressure of gas always 760, but nitrogen's always a constant. So have two other factors, which is oxygen and CO2 affected, you know. So if O2 still normal, so then CO2 must be a normal, right? So then doesn't have a respiratory acidosis. But if my respiratory acidosis, if my CO2 so increase because due to acidosis, due to ventilation, something wrong with the respiratory system, get airway thing, CO2 increase, so then we know this O2 has to be decreased because must have to equal 760 millimeter mercury. So therefore every time you have a respiratory acidosis from any cause, you have a hypoxemia because O2 decrease, and you know, so due to O2 decrease because low partial pressure of oxygen, arterial PO2 because low arterial PO2, so increase CO2 so equals decrease PO2 and vice versa in respiratory alkalosis. Now ventilation defects. Ventilation defects best example is respiratory distress syndrome, also known as high yellow membrane disease in children. In adults, so this is called adult RDS, which is adult respiratory distress syndrome, and has ventilation defect. So lost ventilation to the alveoli, but still have perfusion. So ventilation decrease, but perfusion still normal. Therefore, have created intrapulmonary shunt. Example, for example question, we have a question, patient with hypoxemia, so given 100% of oxygen for 20 minutes and PO2 did not increase. In this case, uh, for example, we diagnose a patient have a hypoxemia with low oxygen, and then we give the 100% of oxygen, for 20 minutes, but the PO2 still not increase. So then what we think about, so this one, so indicates have a shunt, so massive ventilation defect. Next one, talk about perfusion defects. Ventilation defects, which is ventilation because defects which is ventilation, something wrong with ventilation, which is lost ventilation, and I realize blood perfusion intact. Okay, create the intrapulmonary shunt. Resemble if patient have a hypoxemia, give 100% of oxygen for 20 minutes, and PO2 still did not increase. So did not increase, therefore indicates a shunt, a massive ventilation defect. So now talk about perfusion defects. Now talk about perfusion. Knock off blood flow. Most common cause of perfusion defect is a pulmonary embolus. Pulmonary embolus, especially in prolonged flights, with sitting down and not getting up, stasis in veins. So talk about embolus, which is in vein. Talk about thrombus, which is in artery. So thrombus in artery, myocardial infarction, and embolus in vein. Talk about pulmonary embolus. Oh, that's how about we can make the key thing like that. Earlier we talked about thrombus, right? Thrombus in artery, right? Thrombus in artery, a most common cause of death in USA, which is a myocardial infarction, which is thrombus. Talk about ischemia, but talk about embolus, which is in vein, pulmonary embolus. So, for example, in the prolonged flights, with sitting down and not getting up, so stasis in veins of the deep veins, so leads to propagation of a clot, and 3-5 days later, an embolus develops and embolize. So around 3-5 days later, cause embolus because sitting so long. So people who work in the office sitting so long, or in the long fly, international flights, because that, because stasis in veins of the deep veins. DVT, we heard the term which is DVT, deep venous thrombosis, or DVT different with thrombosis, deep venous thrombosis. Hmm. So okay, let me take it back. Before I said the thrombus, that's in artery, myocardial infarction. But in vein, we also have the term DVT. Remember that condition they call the deep venous thrombosis. Thrombosis, which is thrombus. But now talk about vein stasis, which is embolus, like a pulmonary embolus in the prolonged flights. Okay, anyway, just keep that in mind. So, which is stasis in veins of the deep veins, with deep veins that lead into propagation of clot. So embolus, think about clot. How about AFib? AFib, AFib, which is atrial fibrillation. They did not, you know, squeeze the heart, enough squeeze in regular way. It's a fibril like that. so not effective for every single bit. So that's why they form clot, right? That's dangerous because get clot and pumping and they lock. So this is they lock what? They lock artery or they lock arterial system or they lock venous system. I think this is artery system. Yeah, that's why they're dangerous because if when the clot waves from heart when they pump get into the brain and cause trouble somewhere else cause trouble. So that's why if they need to use anticoagulant. Okay, keep that in mind. In this case, you have so talk about perfusion defects, knockoff blood flow. Most common cause perfusion defects, which is pulmonary embolus, especially in prolonged flights. But sitting down and not getting up, stasis in veins of deep veins leads to propagation of the clot, and 3-5 days later, an embolus develops. Remember, it's not developed right away, but around 3-5 days later, the envelope the develop embolus, so then cause the embolization. So in this case, you have ventilation, which is breathing normal, but no perfusion. So therefore, there is an increase in dead space. So this is called talk about pulmonary embolus. So which is ventilation normal, but perfusion defects. So in this case, which is the increase of dead space, if you give 100% oxygen for perfusion defect, oxygen partial, so arterial partial pressure of oxygen, arterial PO2 will go up. Way to distinguish ventilation from perfusion defect because not every single vessel in the lung is not perfused. Therefore, perfusion defects because increase of dead space, while ventilation defects cause intrapulmonary shunt. Uh, when talk about ventilation defects, so we just think about shunt, intrapulmonary shunt. That's simple. Doesn't matter. We give the one even we give 100% oxygen, but just because ventilation defect, perfusion normal, huh? We give 100%, but oxygen still not increase. Okay, but in perfusion defect, we think about pulmonary embolus, which does increase the dead space. Perfusion defects, which is correlated with dead space, but ventilation defect correlated with shunt, intrapulmonary shunt. Perfusion defects, which is dead space. Therefore, perfusion defects because increase in the space, while ventilation defects cause intrapulmonary shunts. To tell the difference, we just give 100% oxygen and see whether PO2 increase or not. If PO2 stay the same, then we know that's a ventilation defects. We do to we going to have a shunt. But if PO2 increase, then we know that is a perfusion defect. Perfusion defects which increase the dead space. Now next one talk about diffusion diffusion defect. So diffusion defect, which is something in the interface that oxygen cannot get through. For example, condition they call this a fibrosis. Past example, which is sarcoidosis, that's a restrictive lung disease. Oxygen already have trouble getting through the membrane, so with fibrosis it is worse. Another example, pulmonary edema. So number one, fibrosis. Number two, which is pulmonary edema. Something in the interface of oxygen cannot get through. It's a fibrosis. In the restricted lung disease, which is sarcoidosis, oxygen already have a trouble getting through the membrane. With the fibrosis, it is worse. Another example, which is pulmonary edema. Oxygen cannot cross, therefore there is a diffusion defect. Another example is plain old fluid from heart failure leads to dyspnea because activated J reflex is innervated by central by cranial nerve 10. So activated of the cranial nerve 10 leads to dyspnea, so cannot take a full breath because fluid in interstitium of the lung and J receptor is irritated. These are four things that cause hypoxemia. So respiratory acidosis, number one. Number two, ventilation defects. Number three, which is perfusion defects. And last one, which is diffusion defects. So diffusion defect, which is something in the interface of oxygen diffusion, oxygen cannot get through. For example, condition. Think about fibrosis. Fibrosis. So, for example, sarcoidosis. So this is a restrictive lung disease. So oxygen already have a trouble get through the membrane. So with fibrosis, it is worse. Another condition which is sarcoidosis, fibrosis, another which is pulmonary edema. So pulmonary edema which oxygen cannot cross, therefore have a diffusion defect. Another example which is old fluid there, for example, this in heart failure. From heart failure leads to dyspnea, difficult breath, difficult breathing. So because activated J reflex is initiated by cranial nerve number 10. Activated cranial nerve number 10, so leads to dyspnea, cannot take a full breath because fluid in interstitium of the lung. So in the heart failure, so have a lung trouble. So lung will build up the fluid as well. This is all fluid. So J receptor is irritated. So if a condition fibrosis, sarcoidosis, or restricted lung disease, or pulmonary edema, or heart failure, when talk about fibrosis, then we think about that's a restricted lung disease, which is a sarcoidosis. That's a fibrosis. Think about restricted lung disease, sarcoidosis, or pulmonary edema, or heart failure. That's a diffusion defects. So now talk about there are 4 causes of hypoxemia. Remember, hypoxemia also cause of hypoxia. 4 causes of hypoxemia. Number 1, which is respiratory acidosis. Number 2, which is ventilation defects. Number 3, which is perfusion defects. And the last one, which is diffusion defects. Respiratory distress, respiratory acidosis. Okay, number 1, number 2, which is ventilation defects. Number 3, which is perfusion defects. And the last one, which is diffusion defects. Now, next one talk about hemoglobin related hypoxia. In the case of anemia, the classic misconception is hypoxemia. Hypoxemia, which is decrease in the PO2. There is no hypoxemia in anemia. Keep in mind like that. in the case of anemia, the classic misconception, which is they think wrong about that, is hypoxemia. No hypoxemia in anemia. Remember that. Which is no low PO2 in anemia. You know, hypoxemia, which is low PO2, huh? But in anemia, no low PO2. There is normal gas exchange, so normal respiration. So there is normal gas exchange, normal respiration, therefore normal PO2. So in anemia, which is normal gas exchange, because we inhale exhale normally, inhalation, exhalation normal. So therefore normal PO2, normal PO2. So the normal oxygen saturation, right? But there is a decrease in hemoglobin. There is a decrease in hemoglobin. So that is what anemia is. So in anemia, which is due to decreased hemoglobin, which is unable kind of, let's say the low red blood cell, and then low hemoglobin. So in that condition, low hemoglobin, but because the patient breathe in, breathe out normal, so then that's why PO2 normal, then oxygen saturation normal, but hemoglobin decrease. So that is what anemia is, which is decrease in hemoglobin. Keep in mind the concept different, huh? Anemia totally different with hypoxemia. Hypoxemia, the term tell us which is low PO2, right? And low PO2 due to, and we know that respiratory acidosis or ventilation, something wrong with breathing in, breathing out, then low PO2. Keep in mind low PO2, which is low oxygen saturation, or perfusion defects, or diffusion defects. But anemia different. Anemia, so so doesn't involve with the ventilation at all. So ventilation, which is breathing in, breathing out normal. So that's why PO2 and oxygen saturation normal. Okay. But anemia, that stands for hemoglobin decrease. Hemoglobin decrease, which for example red blood cell decrease, or some reason they cause hemoglobin decrease. Maybe we need to talk about the cause of hemoglobin decrease later. Okay, now, so that is anemia which is decreased hemoglobin. If you have a 5 gram of hemoglobin, there's not a whole lot of oxygen gets to tissue. Therefore, get tissue hypoxia, and the patient has exertional dyspnea with anemia, so exercise intolerance. Anemia, which is decreased hemoglobin, but you know, PO2 and oxygen saturation normal because nothing wrong with ventilation. Okay, so if you have a 5 gram hemoglobin, there is not a whole lot of oxygen that gets to the tissue, therefore get tissue hypoxia. Huh. When patient has exceptional dyspnea with anemia. Exercise intolerance. You could not understand much. Okay. Now talk about carbon monoxide. Carbon monoxide. That's a classic heater in the winter in the closed space. With the heater have a many combustible materials, automobile exhaust, and house fire. In the house fire scenario, two things cause tissue hypoxia. Number one, due to carbon monoxide poisoning. Number two, which is cyanide poisoning. So in house fire, which is CO poisoning, which is carbon monoxide poisoning, and cyanide poisoning, because upholstery is made of polyurethane products. So polyurethane, which is called cyanide. When there's heat, cyanide gas is given off. Therefore, patients from house fires commonly have carbon monoxide and cyanide poisoning. CO is very diffusible and has a high affinity for hemoglobin. Therefore, the oxygen saturation, which is oxygen bind with the hemoglobin. So here, which is CO2, they bind all hemoglobin. So I mean almost hemoglobin. So no oxygen. So oxygen unable to bind hemoglobin. So talk about oxygen by hemoglobin that we could talk about this oxygen saturation. So oxygen saturation, oxygen by hemoglobin, which is oxygen and carry to the to the organs in the body. So because reduced oxygen binding hemoglobin stand for oxygen saturations decrease because it's sitting on the heme group instead of oxygen. So CO2 they sit there, so oxygen cannot take the chair, right? So remember that CO2 have around more than 200 times affinity for hemoglobin than oxygen. So that's the reason why. So when have a CO2 and oxygen cannot bind hemoglobin. Hemoglobin is normal. It's not anemia. This hemoglobin normal, huh? So if hemoglobin normal, then that's not anemia. PO2 also normal, right? So PO2, which is oxygen dissolved in the plasma, which is ventilation normal, let's say like that. But the oxygen saturation decrease. So so in the case of the carbon monoxide or cyanide poisoning, carbon monoxide carbon monoxide, which is because of carbon monoxide CO they bind to the hemoglobin, which is strongly, which is 200 times. So more than the oxygen binding with the hemoglobin. So if CO exists, so then the oxygen unable to bind hemoglobin, so then decrease oxygen saturation. But hemoglobin still normal, and and the arterial partial pressure oxygen, which is a PO2 normal, but O2 saturation decrease. Now, in this case, now we have to understand, which is this a one-way street like this. What do I mean by this? I would like to mention that this when PO2 decrease, automatically we know which is oxygen saturation decrease because oxygen saturation totally depend on the PO2, which is oxygen dissolved in plasma, right? So if oxygen dissolved in plasma decrease, then eventually oxygen saturation decrease. But in the opposite way, we cannot tell. We can what do I mean like this? I mean oxygen saturation decrease not necessarily mean the PO2 decrease, which is in this scenario in the CO poisoning. CO poisoning, the patient ventilation normal, right? Which they get the PO2 normal, but just because CO binds strongly with the hemoglobin, so then even you have a loss of oxygen there, but because CO they take the seat, they take the chair already, so then Oxygen cannot bind with the hemoglobin. If reduce oxygen binding with hemoglobin, so which is reduce oxygen saturation. See that? So that's why in case of oxygen saturation decrease, that we cannot say PO2 also decrease. It's not it's not a superlative concept there. You know what I mean? So so in the case of PO2 decrease, and we know automatically we know this oxygen saturation decrease. But in case of oxygen saturation decrease, we cannot tell PO2 also decrease because in this case, PO2 normal, huh? But oxygen saturation decrease. The reason because CO they buy, they buy all of or almost of hemoglobin. Clear, huh? They're very detailed here, so have to understand. Hemoglobin normal, so they're not anemia. And PO2 also normal, but oxygen saturation decrease. So keep in mind that. Hemoglobin normal is not anemia. PO2, which is oxygen dissolved in plasma, normal too. When oxygen diffuse into red blood cell, got CO2 already sitting there, so CO have a higher affinity for hemoglobin. So that's why oxygen unable to bind. So to treat, we give the 100% oxygen because we hope, give 100%, which is high oxygen like that. We hope they're able to buy the rest of the seats available there, empty slots there in him. So decreased oxygen saturation, this a clinical evidence is cyanosis. If we see oxygen saturation, so if we see patient cyanosis, which is pale looking, and we can tell that is a decrease decrease oxygen binding with hemoglobin. So not seen in carbon monoxide poisoning because cherry red pigment mask it. Oh, in carbon monoxide poisoning, we not see cyanosis because what? Because cherry red pigment masks it. Oh, therefore makes a diagnosis hard to make. Oh, the reason because in the carbon monoxide poisoning, they have a one thing confused. I mean, this is a mass, so that's why I cannot diagnose cyanosis right here because the condition they call cherry red pigment, the mass it. So we use red color, so that's why the mass of cyanosis which is pale. Therefore, diagnosis very hard. So most common symptoms in cyanosis poisoning, which is headache. So that we ask the patient, you had a headache or not? The patient say yes. Okay. And also measure the oxygen saturation. Now talk about methemoglobin. make hemoglobin. This is iron 3 plus, iron 2 plus, which is this iron able to bind thing, but iron 3 plus, which is uh, oxygen cannot bind. So if met hemoglobin, it is a met and hem. That stands for hemoglobin 3 plus. So on the heme group. So if iron 3 plus in heme group, so it's not iron 2 plus. So then because iron 3 plus, so that's why oxygen cannot bind. Therefore, in hemoglobin poisoning, the only thing screw up is oxygen saturation because the iron is 3 plus instead of 2 plus. So example, patient has a draw blood which is chocolate color because there is no oxygen on heme groups. So which is this oxygen saturation decrease. So but normal PO2, normal partial pressure of oxygen, which is arterial PO2, normal, but the oxygen saturation decrease. The reason because similar like carbon monoxide, not totally the same. I say the word similar. The reason because the iron 3 plus they sit in the heme group hemoglobin, so then oxygen cannot bind hemoglobin. So that's why oxygen saturation decrease, but PO2 normal because nothing wrong with the ventilation, right? Hemoglobin also normal, right? So in this case, only oxygen saturation not normal, which is decrease. So seat is empty, seat available there, but cannot sit in it. The reason because iron 3 plus, you know, keep in mind iron 2 plus, which is oxygen can bind it, but iron 3 plus, oxygen cannot bind it. So red blood cell have a hemoglobin reductase system in glycolytic cycle. So reduction can reduce 3 plus to 2 plus. So if like that, then we need to give more this system which is make hemoglobin reductase. The enzyme reductase that indicate which is they reduce make hemoglobin. So in red blood cell, they have the system they call this make hemoglobin reductase system, which is they reduce the make hemoglobin, which is they reduce iron 3 plus, so 2 plus. When iron 2 plus, then oxygen can bind. For example, patient from Rocky Mountains was cyanotic. They give him 100% oxygen, and he was still cyanotic. Oh man, wow. So then that we know this is hemoglobin. So was drinking water in mountains. In Rocky Mountain have some kind of something wrong with the water there because the water they contain a lot of the nitrates, so which are oxidizing agents. The oxidized hemoglobin, so the iron it becomes 3 plus instead of 2 plus. Oh, very interesting here. In Rocky Mountain water, they contain a lot of nitrates, and nitrates, which is oxidizing agents. So they oxidize, because oxidize them for what? Oxidize hemoglobin. Oxidize hemoglobin, remember that? Could not understand thoroughly about chemical reaction here. But keep in mind, this is an oxidizing agent. They oxidize hemoglobin. So then oxidize, then iron become a 3 plus instead of 2 plus. The clue was oxygen did not correct the cyanosis. So even we give the 100% oxygen, but the patient still cyanotic. The reason why? The reason because even you give whatever oxygen, but because they have iron 3 plus, their oxygen cannot bind with the heme. Doesn't matter how much you give oxygen, but the oxygen cannot correct situation. So treatment IV methylene blue is a drug of choice. Ah, we give the intravenous methylene blue. Keep in mind methylene blue, huh? This one or ancillary treatment which is vitamin C. Oh, or reducing agent. So vitamin C very important in this scenario too. More recent drug which is Dapsone. So used to treatment leprosy, huh? We know that, huh? Hansen disease. So Dapsone is a sulfur and nitro drug. Therefore, those two things produce and make hemoglobin gì đây? Let me read again. It's a little bit confused here. So keep in mind, in the make hemoglobin doesn't matter 100% oxygen provided in there, but they cannot correct the condition cyanosis. The reason because iron plus 3 they sit in there, so oxygen cannot bind to heme group. So that's why you give 100% oxygen but cannot correct the situation. So what's the drug of choice here? They use this they use IV IV methylene blue. Methylene blue this can correct condition. Or vitamin C and vitamin C as well, which is ancillary treatment. Vitamin C. Now talk about this drug now. The Dapsone recent drug which is Dapsone, which is the drug treatment for Hansen disease, leprosy. They contain a lot of sulfur and nitro. So therefore, this drug causes two things. Number one, cause a methemoglobin. Number two, have potential in produce hemolytic anemia. In GCPD deficiency. Therefore, hemolysis in GCPD deficiency is referring to oxidizing agents causing increase in peroxide, so which destroys red blood cell. Let's say hemolysis in GCPD deficiency referring oxidizing agents causing increased peroxide, which destroys red blood cell. The same drug that produce hemolysis in GCPD deficiency are sulfur and nitro drug, which is Dapsone. Dapsone drug they cause two things. Number one, which is methemoglobin. Number two, which is the potential producing hemolytic anemia in the patient GCPD deficiency. In patient GCPD deficiency, hemolysis referring to oxidizing agent, which is sulfur and nitro. Oxidizing, which is called ethylene peroxide. So increased peroxide they will destroy red blood cell. So these drugs also produce methemoglobin. Therefore, exposure to Dapsone, Primaquine, or TMP, SMS, which is trimethoprim, sulfamethylcesone, or nitro drugs, which is like a nitroglycerin, nitroprusside. There can be a combo of hemolytic anemia, GCPD deficiency, and methemoglobinemia. Okay, because they are oxidizing agents. Common to see methemoglobinemia in HIV because some patients they use a trimethylcream sulfamethylcesone to treat PCP, you know. Therefore, potential complication of that therapy is a methemoglobin. Ah, so in the patient HIV, yeah, they use the drug trimethylcream sulfamethylcesone to treat the PCP because this they cause methemoglobin in HIV patient. Keep in mind that. Now, next one, which we talk about the curves, left and right shifts. One, the right shifted curve. So one hemoglobin with the decreased affinity for oxygen, so it can release oxygen to tissue, causes 2,3 BPG, which is by phosphoglycerate, fever or low pH, acidosis, high altitude, which have low oxygen, which has low oxygen, but this one due to the respiratory alkalosis, high oxygen condition with low CO2, which is alkalosis. And then this one due to breathing, so that's why they call respiratory alkalosis. Therefore, have to hyperventilate, to get it off because you will decrease the CO2. What? Say that again. In high altitude, which is a condition which is low oxygen, which is high CO2, then this a respiratory alkalosis. Actually, high CO2 have to be respiratory acidosis, man. Therefore, have to hyperventilate, to get it off the CO2, right? And get more oxygen. Leading to right shift because there is increased synthesis of 2,3 by phosphoglycerate. That's a right shift and left shift condition, which is carbon monoxide, methemoglobin or hemoglobin F. In this condition, which is decreased to 3 BPG, which is bisphosphoglycerate or alkalosis. Therefore, with the carbon monoxide, there is decrease in oxygen saturation, hypoxemia, and left shift. Anyway, okay, complicated that. So, my summary today, we talk about hypoxemia, but did not finish hypoxemia yet. Okay, so try to finish hypoxemia. Now talk about next one, problems related to oxidative pathway. So most important, which is cytochrome oxidase, the last enzyme before it transfer electron to oxygen. Remember 3C's, which is cytochrome oxidase, cyanide, carbon monoxide, all that inhibit cytochrome oxidase. So cytochrome oxidase, cyanide, and carbon monoxide. So cyanide, carbon monoxide, which inhibit enzyme cytochrome oxidase. Therefore, three things for carbon monoxide, which is degree oxygen saturation. Number two, which is left shift. And number three, if you were able to release it, then it blocks cytochrome oxidase. So the entire system shut down. Oh man, that's dangerous, huh? So keep in mind, this carbon monoxide poisoning very dangerous because they cause three things. Number one, we know oxygen saturation decrease. Number two, which is the left shift, which is so the little you carry, you cannot release. Number three, which is if you were able to release it, let's say treatment carbon monoxide, we do 100% oxygen. If you are able to release them, then it locks cytochrome oxidase. Given by cytochrome oxidase, which is transfer electron to oxygen, the last enzyme before it transfer electrons to oxygen. Cytochrome oxidase. B. This talk about uncoupling ability for inner mitochondrial to synthesis energy, synthesis ATP. So synthesis ATP in the inner mitochondrial is my inner mitochondrial is permeable to protons. You only want protons to go through the certain pore where ATP synthase is the base leading to production of ATP. You don't want random influx of protons, and that is what uncoupling agents do. Examples: dinitrophenol, chemical for preserving wood, alcohol, or salicylates. Oh, salicylates, which is aspirin. So uncoupling agents cause a proton to go right through the membrane. Therefore, you are training on the protons and very little ATP being made because our body is a total equilibrium with each other. Reactions that produce protons increase reaction that make NADH and FADH. These were the protons that were delivered to the electron transport system. Therefore, any reaction that makes NADH and FADH that leads to proton reduction will wrap up reaction, making NADH and FADH to make more protons, which increase the rate of reaction, leads to an increase in temperature. Therefore, we see hyperthermia. So if poisoning of the dinitrophenol DNP, which is chemical for preserving wood, or poisoning alcohol, or poisoning of salicylates, which is aspirin. This thing they can cause a hyperthermia, which is feel hot. Oh, interesting, huh? Complication of salicylic toxic. Oh, poison, aspirin poisoning, salicylic toxic. The cause is a warm, which is a overheat, hypothermia. Oh, I thought different. I thought it's a cold skin. Actually, this is overheat. Keep in mind that because it is an uncoupling agent. Another example, which is alcoholic on hot day will lead to heat stroke. Ah, because already have uncoupling of oxidative phosphorylation because mitochondria are already messed up. So let's say salicylic toxic patient they just give the baby aspirin every day like that, or even some patient they give 325 milligram. Oh man, every day they take like that. Not sure they get the poison or not, poisoning, salicylic poisoning or not. Interesting here, and not sure how much is overdose, how much is a toxic. So, or I mean, even use a short time is too much, or even long run, they use every day for that and they accumulate and they got toxic as well or no? Need to understand that. Anyway, these are all the causes of tissue hypoxia. Number one, which is ischemia, hypoxemia, ischemia, and hemoglobin related cyto cytochrome oxidase block and uncoupling agents. So absolutely key things. So keep in mind cause of the hypoxia, the tissue hypoxia, is ischemia, hemoglobin related, cytochrome oxidase block, uncoupling agent. So keep in mind these are key things. So don't know until when we can master those concepts. I mean, just talk about that and we just know that right away. Now, what happens when there is respiratory acidosis? Respiratory acidosis, which is what talk about acidosis, which is high CO2. Problem with the breathing in, breathing out. That's why due to this respiratory. Uh, it's not metabolic, but just this respiratory acidosis, which is high CO2, which is low O2. I mean low PO2, low PO2, which is low oxygen saturation, but hemoglobin normal, right? So that we know that. How about anemia? Anemia, which is hemoglobin normal. Anemia, so not involved with the breathing in, breathing out, right? Hemoglobin in anemia, which is hemoglobin abnormal, which is decreased, but PO2 normal and O2 normal, or PO2 normal and oxygen saturation normal, huh? And how about in condition this is a carbon monoxide or hemoglobin? That is due to which is a carbon monoxide, which is they buy hemoglobin, so oxygen cannot buy. Or in hemoglobin, which is they create iron 3 plus, so oxygen cannot buy. Technically, in these conditions, which is oxygen saturated decrease, but partial pressure of oxygen, which is PO2 normal, and hemoglobin also normal amount. Okay. Now, how about treatment for carbon monoxide 100% oxygen, and treatment for methemoglobin, which is the yield of methylene blue, and vitamin C, which is ascorbic acid. Okay. Next one, decrease ATP as a result of tissue hypoxia. So most important have to go into anaerobic glycolysis. So glycolysis end product is lactic acid. Pyruvate is converted to lactate because of increased NADH. Need to make NAD so that the NAD can fit back into the glycolytic cycle to make two more ATP. Why do we have to use anaerobic glycolysis with tissue hypoxia? Mitochondria are the one that makes ATP. However, with anaerobic glycolysis, you make two ATP without going into the mitochondria. Every cell, including red blood cell in the body, is capable of performing anaerobic glycolysis, therefore surviving on 2 ATP per glucose. If you have a tissue hypoxia, mitochondria system is totally shut down. No oxygen at the end of the electron transport system, can only get to ATP with anaerobic glycolysis. Good news, get to ATP. Bad news, build up a lactic acid in the cell and outside the cell. Increase anion gap metabolic acidosis with tissue hypoxia due to lactic acidosis from anaerobic glycolysis. However, causes havoc inside the cell because increase of acid within the cell will denature proteins. With structural proteins mess up, configuration will be altered. Enzymes will be denatured too. As a result, cells cannot auto-digest anymore because enzymes are destroyed. Because build-up of acid, tissue hypoxia will therefore lead to coagulation necrosis, also known as infarction. Therefore, build-up lactic acid within the cell will lead to coagulation necrosis. Oh man, it's so deep. Number two, second problem of lacking ATP, which is all ATP pumps are screwed up because they run on ATP. ATP is a power used by muscle. The pump, anything that needs energy needs ATP. Sodium potassium pump blocked by digitalis to allow sodium go into cardiac muscle. So calcium channels open to increase force of contraction. Therefore, sometimes you want the pump blocked and sometimes you want to enhance it. With no ATP sodium into the cell and it brings water, which leads to cellular swelling, which is reversible. This reversible, huh? Therefore, with tissue hypoxia, there will be swelling of the cell due to decreased ATP. Therefore, we'll get oxygen back and will pump it out. Therefore, it is reversible. So they say, therefore, the tissue hypoxia, there will be swelling of the cell due to decreased ATP. Therefore, we get oxygen back and will pump it out. That is reversible. In true red blood cell anaerobic, so without oxygen, glycolysis is the main energy source because they do not have a mitochondria. In red blood cell, they don't have a mitochondria. Not normal in other tissues want to utilize. So FA, TCA, etc. Now, free cell without oxygen leads to irreversible changes. So cancer changes will irreversible damage. So cancer changes, calcium changes will irreversible change damage. Calcium ATP, ATPase pump. So with decrease in ATP, calcium have easy access into the cell. Within the cell, it activates many enzymes like a phospholipases in the cell membranes, enzyme in the nucleus, leading to nuclear pyknosis. So the chromatin disappears. So into goes into the mito and destroy it. So without ATP or ATP decrease and calcium easy to get into the cell and they activate so many enzymes so like phospholipase in the cell membranes in cell membrane or enzyme in the nucleus leading to nuclear pyknosis. So the chromatin disappears. So go into the mito and destroy it. Calcium activates enzymes hypercalcemia leads to acute pancreatitis. Oh wow. In a condition with high calcium in the blood, they can cause acute pancreatitis because the enzyme in the pancreas have been activated. So therefore, irreversible changes. Oh man, that's a dangerous. So calcium is a major role of the two that get damaged, mito and cell membrane, mitochondria and cell membrane. So cell membrane damage a lot worse, resulting bad things from the outside to get into the cell. Oh, wow. However, to add insult to my to injury, knock off mitochondria, energy producing factory. It is a very bad situation. Cell dies. CKMB for mito so my for MI cardio infarction and transaminases for hepatitis, SGOT, and and ASD, ALT, amylase, hemochromatitis. Oh wow, so many things we covered today. Anyway, so that we talk about that. Okay, let's summary. So talk about hypoxia and term which is oxygen content, which is hemoglobin oxygen saturation, and partial pressure arterial oxygen. So we know partial pressure of oxygen, we over arterial oxygen, this oxygen dissolved in the plasma. Oxygen saturation, which is the thing by in the heme in the hemoglobin in heme in red blood cell. So the cause of tissue hypoxia, here we talk about ischemia. Most common, second most common, which is hypoxia. Hypoxia talk about respiratory acidosis, ventilation defects, perfusion defects, and diffusion defect. And talk about hemoglobin related hypoxia, which is carbon monoxide, methemoglobin, and cause left shift, which is carbon monoxide or methemoglobin or hemoglobin F. Now talk about problem related to oxidative pathway, cytochrome oxidase, uncoupling agent. So like that. Let's talk about decrease in ATP. Most important have go into anaerobic glycolysis. Second problem is a lacking ATP. Cell without oxygen lead to irreversible changes. For example, too much calcium, they can cause trouble. Okay, so that's what we cover for today. So thank you very much everybody for watching my live stream. Next time we will cover free radicals.